see it fall.
I don't mind at all.
I appreciate you.
As long as you
Why did
subscribe
it
to my
just do
channel.
I know you.
Sexy like a chocolate strawberry. Double dip, baby.
All right.
First in the
All
chocolate.
right, T.
Yummy.
We like 20 slides. All right. Etiology and path of hypothyroidism. Hypothyroidism is one of the most common disease processes that we have, and it's one of the most common defaults. I cannot tell you how many people I've said, well, I've gained a little bit of weight. Oh, it's my thyroid. No, you just gained some weight. I mean, just stop it. You're just blaming your thyroid. Nothing's wrong with your thyroid.
Mine's obviously bad.
Mine's horrible. It's so hypo. No, it's absolutely fine. I just haven't started working the baby fat off yet. All right.
Hopefully mine could be bad.
All right. Thyroiditis. Inflammation of the thyroid gland. It's pretty self-explanatory, right? The same causes you're going to get with an inflammation for anything. Viral infection, bacterial infection, fungal infection, a chronic autoimmune disease. All right, here's my little guy. Any questions?
What is the likeliness if, like, your mother and your sister had hypothyroidism?
It's pretty high, because it's very much genetic. Then I would say see if your doctor will just do a blood test to see what your levels are. Any questions on my little cold guy? Why does he have body lotion?
Dry
Because your
skin.
skin gets ridiculously dry, especially in the winter. It can get so dry in the winter, it feels like your skin's burning. All right, complications. Mental sluggishness. This is someone that's easily forgetting stuff, but they have no idea why they're forgetting it. You may know why hypothyroidism causes mental sluggishness.
Metabolism slower?
Hmm?
Your metabolism slower?
Your metabolism is slow. Your body is not responding as fast as it normally does. Drowsiness, lethargy. Predisposing factors. Some sort of blood infection that goes to the thyroid. Certain drugs, both legal and illegal. An intense exposure to cold. I mean, like hypothermia. Where, remember, that thyroid is not too far away from here. There's really not a whole lot preventing any environmental factors. So if you have someone that falls in the ice because they parked their car on Lake Geneva 2 years ago and their car fell through, even though there was multiple people there saying, no, don't do it. There's no shacks out there. Nobody's fishing, which means all the people that know how to fish on the lake are off, which means you probably shouldn't be parking your brand new Escalade there. They didn't listen. Somebody did fall in the water, but it was only like waist deep. But for somebody that truly falls in and it's submerged, they will have thyroid problems later on and some sort of trauma to the area.
So you shouldn't do the polar plunge? So you should never do the polar plunge?
You know, that's a small amount of jumping in. I would never personally do the polar plunge because it looks very uncomfortable. And if I'm going to go jump in a pool or a lake, I want it to be warm like that. Okay. Well, we skip this slide. All right, let's just go to hypothyroidism as well. These are your two blood tests, TSA and a free T4.
TSA or TSH?
Whatever is on there that I can't seem to say. TSA.
I was
Okay,
on
I'm
those
currently at the
pictures.
airport ready
I was
to
gonna say it.
board somewhere. Let's go. TSA. Yeah, I'm sorry. Oh, Lord. All right. What is the most common treatment for hypothyroidism? You got it, Synthroid. Synthroid is the most common form of medication.
It's the only time that the brand is better than generic.
When it comes to giving the patient this medication, they should start out at a very low dose. This is not someone you want to give a high dose to right away. This is a drug that needs to be gradually increased, and if they ever go off it, it needs to be gradually decreased. It can seriously mess up their lymphatic system. So what kind of diet with someone with hypothyroidism should they be on?
Low calorie.
Low calorie diet because they're more susceptible to gaining weight. And if they're iodine deficient, which most people are that have hypothyroidism, they need either supplements or food high in iodine. Anybody know the one of the highest foods that are high in iodine?
Fish.
I heard it's salt.
Spinach.
Iodine, salt. There is a difference. So if your patient has hypothyroidism and has kidney disease, I don't know what they're gonna have.
Supplements.
Probably, no, because they can't have salt. They can't have salt. All right, nursing assessment. Have you gained weight? And it won't be an overnight gain too. It will be a gradual thing.
Why does it say anorexia and then weight gain? Or, you know, the little guy with the symptoms?
They don't want to eat.
They're still gaining weight.
But you'll still gain weight. You can be
This
anorexic and
one's
still gain
bad.
weight.
I figured it out. That's Julie's one.
You okay?
She's
Did
cheating.
I mess up something? She's cheating on your
No.
slides that you won't
Yeah,
get.
I don't understand.
What's going on? Did I mess up a
Figured it
slide?
out.
Wouldn't be
No.
the first time I messed up a slide.
No, I missed a part, but I figured it
Oh, okay. All right. Amazing. They're fatigued. We already talked about that. Cold intolerance, constipation. So what would be your nursing interventions?
Erosion.
Hmm?
Peak proper use of medication.
Adequate
Proper use of medication?
Adequate nutrition.
Adequate nutrition?
Self-monitoring of weight without
I can't hear. I don't hear what you just said.
Self-monitoring.
of weight
Yeah, there you go,
without
there you go.
nutrition.
And I heard stool softener, not a bad idea. This medication, unless, not unless. This medication, this Synthroid, they will be on the rest of their life. This is forever. This isn't a, okay, I can get off it in a year. You can, absolutely, but then all of your symptoms are gonna come back. And unfortunately, sometimes, just like any other drug, the body eventually will grow used to it and the dose will have to be slowly be higher. The starting dose, though, is ridiculously small. It's 0.10. So it is tiny. It's a tiny little dose. It's a tiny little pill, too. Okay. So, hyperfunction. Cushing's syndrome. Anybody ever heard of Cushing's syndrome before? What do you know about it?
Too much cortisol?
Mm-hmm. You see this a lot too with patients that are on long-term steroid use. You see a lot of Cushing syndromes. Was something you see a lot, especially in men that are on steroids for a long period of time. You get that the rounding of their bony fixtures, and their cheeks get nice and rosy and round. It is just a side effect. It's literally changing the tissue around the face. Because it's a steroid issue, the body is depleting the calcium right out of the bones. So they're at a higher susceptibility to break a bone. So how do we diagnose Cushing syndrome?
Spit swabs.
The what?
For to test the cortisol, they have like a 3-day spit swab. You have to do it at midnight every night.
You can do that?
Yep.
That's something you do at home. What would we do in the hospital?
24-hour urine.
Mm-hmm. Absolutely same collection process as any other 24-hour urine. It's just that we're seeing what the cortisone levels are. CT and MRI can be done of the actual thyroid to see if it's enlarged or if there's any inflammation going on.
Can you explain the low dose of the suppression test? Would that just suppress the thyroid and you would see if their symptoms went down?
Mm-hmm.
Okay.
So surgery for Cushing syndrome. Surgical removal of the pituitary gland. We don't do it unless we absolutely have to, because it is kind of in a delicate spot. But if the Cushing syndrome is that bad and the symptoms have gotten that severe that medication's not doing anything, we will go in and take it out. So what is your surgery care?
Control hyperglycemia and hypertension.
Yes. The blood sugars will shoot up and so will your blood pressure for no physiological reason other than the fact that we are messing with the hormones, we're messing with the cortisone levels in the body very rapidly. It also drops your potassium level. So we'll constantly be monitoring potassium while the surgery is going on. This is another patient that needs high protein diet. And what kind of post-op teaching may the patient have? Doesn't mean they always will have this, but post-op surgery, what can they expect when they start waking up? What's some normal things a post-op patient would have?
Pain.
Little pain.
Talk.
They might be not able to talk. Why?
Because of the
It
swelling.
might
Right
hurt.
above your voice box.
Mm-hmm.
Okay.
What else might be still down the throat? No, hope not.
Would swallowing be difficult?
What'd you say?
Intubated.
Nope. They're waking up. But they can be waking and talking. What can still be down the throat?
The breathing.
Nope. I hope not. That'd be really impressive if they were talking with breathing too good.
And
There you go, NG2. They may have an NG2 now. And then just the regular stuff. They're going to have the IV still going for pain medication. They may or may not have a Foley catheter. This isn't someone we want getting up a whole lot right away because those muscles are not thick. Okay? We don't want them straining when they're getting up. We're going to be checking their blood pressure pretty often and their electrolytes. So let's talk about the actual post-op care. They're going to be on some high doses of cortisone steroids for a couple days. I mean high. I mean, like, you want to call the doctor and make sure this is actually what he meant when he put the order in the chart high. Does anybody know a ridiculously annoying side effect of high doses of corticosteroid?
it's like you can't concentrate, you're really tired.
You're stiff?
Nope.
Sweating.
This lesion
Something
on
in your
your
palm.
palm.
Get your palms.
It will start breaking down the tissue in your palm.
What?
It's not very, you can't really see that on the slide here. It will literally start breaking down the tissue on the palm of your hand and your feet.
Why?
Steroid, just breaking down tissue.
That's weird.
It's what it does. So as we talked, we're gonna monitor for hypertension, heart rate, and anything that's associated with any type of surgery, okay? Decreased wound healing. We are giving someone high doses of steroids. What do steroids don't want your body to do?
Heal.
It's a very difficult time healing. So that is why it starts breaking down other tissue. We'll be routinely checking the cortisone levels just to make sure they're either staying stable or going down. So they're going home, everything, whew, okay, we're good, we're out of the hospital, we're going home, right? They need some kind of medical bracelet. High doses of steroids they'll have for pills for quite some time, and those can cause some nasty side effects. I have had patients that had this surgery, and then about 6 months after surgery, their doctor says, well, we're getting all their records ready to go in. They can't take the Midwest anymore during the winters. They're in pain because everything that used to regulate those hormones is now gone. There is any, and they move south. So I don't blame them. Infections, remember, corticosteroids, poor healing process, easier infections. Emotional disturbances. Yes, they get these. Hallucinations. I would describe it as a mood swing, like a pregnancy mood swing.
Is that because of the steroids? Okay.
The steroids just change the hormone, and you've lost a gland that helps regulate those same hormones. So now they can spike without any type of warning. If the patient is under extreme amount of stress, what tends to happen to those corticosteroid levels? They shoot up, and then they have an emotional disturbance, and then they have a mood swing, and now your body's not healing. So those medications will be adjusted per stress level. So the patient will be instructed, if something were to happen, if you decide to go to nursing school, if you had someone die in the family, you need to call the doctor and they'll be regulating it almost on a daily basis. This is a lifelong therapy too. They're not going off of it. All right, let's talk about the insufficiency. Hypofunction of the adrenal cortex.
Addison.
What's that?
Addison's.
Yep, Addison's. Very good. So let's talk about Addison. It is most caused by an autoimmune response, and the tissue is typically destroyed by your own body's antibodies. So remember, when you have an autoimmune disease, your body typically goes after what? Itself. It's fighting itself. Some other causes we've seen is tuberculosis, infarction, so heart attack, fungal infections, AIDS, and metastatic cancer. You'll see Addison's disease, because at that point, it's just invading all the different tissues. So this is what your patient may look like. Any questions there? I had a very lovely patient once that had Addison's disease from a past illness, and she was coming in and we were doing some stuff, and she goes, well, I asked her how it was going. She was on therapy for a while. She goes, it's better. She goes, you know, there's some things I don't like. She goes, got really lightheaded when she stood up. She didn't like that. She had little ones at home. She goes, but hey, I got a tan. She, poor thing, she was trying to find the good part.
I
So-
don't understand why that happens though. I don't know why you turn tan.
I'm sure there's a reason why I've never looked
It's
it up.
weird.
Just like how you turn yellow with winter stuff.
All right. So Addison's disease, what are you going to ask? History and physical.
Does anybody else in your family have it?
Yep. What else?
Any medical conditions?
I'm sorry?
Any medical conditions?
Any medical conditions? Have they had a heart attack? They had tuberculosis. Do they have HIV? Do they have any fungal infections? Those are the things you're going to ask. So we're going to do the history and physical, and then we're going to do the serum cortisone and aldosterone level, and just see where we're at. After all that's said and done, they may or may not do a scan, but that's an option. Why would we want to do an ECG?
Because the electrolytes.
What's part of the history and physical questions?
Oh, the
We don't,
NHS.
they may have not known they had a heart attack. I hook patients up all the time, and they have a reduced QRS, or I'm sorry, not a QRS, they're dead if they have a reverse QRS. ST wave, a depressed ST wave. They never knew they had a heart attack. So it's very possible. What kind of electrolyte levels are going to be adjusted? Is your potassium going to go up or down?
Down.
It's going to go up. Your sodium level is going to go where? Down. Your sugar is going to go where? Down. And the patient may be anemic. So let's talk about Addison's crisis. We're almost done, guys. You have a break. And this is a life-threatening emergency. This is something that we have to go in and get done ridiculously fast. So the first things you're going to see are you're going to see a very severe hypoglycemic case. So what do you have to do for hypoglycemia?
IV and sugar.
IV and sugar. Get it under the tongue, get an IV and get some D5. You're also going to see hypotension. So you're going to be giving D5 and you're going to be giving 0.9 normal saline at the same time. There is typically a reason that someone goes into Addison's crisis. It's not just one day they're just having a bad day and they go into Addison's crisis. Anybody can guess why people typically go into Addison's crisis? They haven't been taking their steroid. They've abruptly stopped their steroid and it's been 4 or 5 days. So if you have a patient that comes in just a routine visit and you're asking them the regular questions, they're like, oh yeah, I had the flu last week, and oh yeah, I haven't taken my steroid in the last 5 days. They're going to be admitted immediately. We have to give them IV steroids and they have to be monitored.
Would this happen to somebody who doesn't even know they have Addison's?
Mm-hmm.
It could.
Mm-hmm. Unfortunately, that's typically when people find out when they come in and we think they're having a stroke, we think there's something else going on. So
So
we do a
then-
blood sugar, and the blood sugar's low, but we give them the D5, but nothing really changes. It's when we start to change their blood pressure, and it starts to go back up.
So then that would just happen because their body is like done trying to.
Compensate.
Okay.
Yeah, they're just done. All right. So again, lifelong replacement. They typically have to take the corticosteroids throughout the day too. It's not like something they can just take in the morning. There isn't like extended release corticosteroids. So they do have to take it throughout the day. If they do miss a dose, they absolutely need to call the doctor or the triage nurse, wherever they're being seen, and let them know that they missed a dose and why. Can they take it right away? Are they out? Are they sick? Are they vomiting? Are they throwing up? Teach about stress management. A stressor will cause an Addison's crisis. And what kind of stuff would you want in their emergency kit?
Sugar,
Sugar,
water,
water,
extra pills.
extra pills, an IM. You can get IM corticosteroids. So this is something we can teach the family to give if they think the patient's in a adenosine crisis. I'm sorry, yeah, not adenosine. Addison's. Adenosine, a cardiac. Addison's crisis. Absolutely. And then really anything that they think would help them calm down. I carry lavender and peppermint with me. Lavender calms me down, peppermint takes my annoying sinus headaches away. So it just depends. That is endocrine. You guys need a break before we go to neuro?
Go short, we can just get this done.
You just want to take 5?
Yeah.
Go to the bathroom, grab something, come right back. Alright, this is what we do need to go over. Level of spinal nerves. So, cervical spine, what does it control?
Diaphragm, chest wall, muscles, arms, shoulders.
Perfect. So if you have someone that comes in with some sort of cervical injury, what is your greatest concern?
Breathing.
Breathing, absolutely. Can they use their diaphragm? All right, thoracic.
Upper body, gastrointestinal function.
So what is your most concerned issue?
Digesting, eating.
Can they eat? Is their body digesting? Are they incontinent?
Dinner at 5.
Mm-hmm. All right, and then lumbar and sacral. Lower body. Again, incontinence, bowel and bladder. Lumbar and sacral are the ones where you get your neural pain in your legs. When you have an injury here, this is one that affects your feet and legs. Very, very typically, if you have a lower back injury, your back might hurt a little bit, but your legs are what actually hurts and throbs.
Does it radiate or?
Because it radiates out. Because the nerves are hurt.
Is it sciatica?
It's a very horrible form of sciatica. I can attest to it because I have it.
Me too.
I have herniated my L4, L5, and S1. I had a 21-hour OR shift. I couldn't walk for a week. And if anybody in my clinical group notices, by the end of the day I'm limping. That's why. My leg hurts that bad. Nothing. There's nothing wrong with my leg, but it's fine. It's my lower
I
back.
thought that was your swag.
No, I'm in pain by the end of the day. Okay, you guys can read. This is just a slide. You guys can read it if you really want to. There's not going to be any of the cranial nerves on the exam. Okay, that's not how I remember it.
Oh, that was terrible.
Oh, so shake it, family, take it.
Okay, it's fine. Again, if you want to look at it, again, I just put it in if you're really curious. So let's talk about fight or flight response. What is fight or flight response?
You're gonna fight or you're gonna flee?
So your bodies they're going to fight for what's going on, or it's going to shut down. All right, neuro assessment. What are some things that you are going to ask a patient for a neuro assessment?
Seizures.
All right, so history, right? So what kind of questions are you going to ask for history?
Do you
Head injury?
Head injury?
Do you have headaches?
Do you have headaches?
Blurred vision?
Blurred vision?
Seeing double, but
Seeing
I'm saying
double.
it's the same. But
Yeah, that's fine.
Um,
Numbness,
Loss
tingling.
of consciousness.
Loss of consciousness. Have you passed out lately? Have you fallen lately? We have to ask that. Have you fallen? Why did you fall? Did you just trip over something? You know, did you fall because it was icy outside and you lost your balance, or did you fall and you were on the floor and all of a sudden you woke up, you don't know how you got there? There's a grave difference. Grave, very grave difference. If you're me, you fall going upstairs.
Same.
All right, pupillary responses.
Perla.
Perla. Everybody remember health assessment? All right, good. Do I have to go over consensual, direct, indirect? We're good.
No.
Fabulous, I will move on. Glasgow coma scale. We need to know this. Has anybody ever done this at clinical?
Yeah.
A couple of you have. I know a couple of you have. Perfect. So, eye opening, is it spontaneous? Are they blinking? Are they responding to you? Do you walk in and say their name and they open their eyes? Or are they a little groggy, maybe sleeping? They only open their eye to painful stimuli? Or there's none whatsoever? Verbal response, motor response, your max score, okay? The max score you can get is 15. The lowest score you can get is 3. Typically, if you're at a 3, you're in a coma and you probably don't have any brain activity, okay?
8 and 10.
Diagnostic exams.
Whoa.
So, lumbar puncture. Why would we do a lumbar puncture? What's really the only thing we do in order?
Measure pressure in the
Check for infection.
What disease process? Someone said it. Meningitis, right? Different types of meningitis. I will tell you right now, if you are going to do a lumbar puncture, you're going to assist a doctor do a lumbar puncture, make sure you make plans for right after it's done for you personally to walk that sucker down the lab. I will let my floor nurses off the floor, or my IC nurses off the floor all the time. Now, they don't love the CNAs and the hucks whatever, but this is not a procedure I want to go back in the room and be like, okay, something happened to it. Don't ever tube this or I'll come and find you and hurt you. Okay? Blood you can tube, urine you can tube. That's easy to replace. CHF fluid, a lumbar puncture, if you've never had one, it doesn't matter how good the anesthesiologist or the ER doctor, it just hurts. It's just you're going through a bunch of nerves. Okay? EEG, what's an EEG do? Why do we do that? Brain activity, perfect. So we do this for a couple different reasons. The patient have a long history of seizures, so we're trying to find out where the seizures are coming from. Do they possibly have some sort of tumor, so we need to locate that from. And then for brain activity itself, if someone's had a massive stroke, if someone's had a head injury, this is the test you hear, well, we've done the test and there's no brain activity. This is the test they're talking about. It does not take long to do and we can do it pretty much anywhere. An EMG, anybody hear what an EMG is?
Electrical activity, muscles.
For muscles, so we're seeing if there's any atrophy going on, we're seeing how well the muscles are responding to you. So then we can do any muscle, any limb. A myelogram detects spinal lesions or cysts in the spinal cord. Cerebral angiography, the brain. MRI, and then Doppler studies. A Doppler study simply is another form of small waves, so it's like an ultrasound machine. Okay.
So is a cerebral angiography like an MRI?
It's kind of like MRI. Yep. All right, meningitis. What are the 3 different types of meningitis?
Fungal, viral, bacterial.
Perfect, fungal. Very good. So what are the treatments for these?
Well, it depends on the type of meningitis you have.
All right, so if you have fungal, what are you going to get?
Fungal.
Bacterial?
Antibiotic.
Viral.
Supportive care?
You treat the symptoms and hope the body can steer the patient back to being healthy.
Is bacterial the one that you have a certain amount of time?
Bacterial will kill you the fastest if
Yes.
it's not treated.
My cousin, he was 92, he went in with like a rash and they sent him back because, I don't know, everyone else was sick and then we brought him back and he
See,
passed away like
The problem with
within 2
meningitis too, the symptoms are so flippin' vague.
And he was a baby, so he can't really express it.
Oh, yeah.
He had like
That's
the
awful.
peaky eye and stuff.
Oh. Because the manifestations for meningitis, any of them, chills, tachycardia, a rash, muscle aches, and the only way you're going to know this is ICP pressure, so brain activity pressure goes up, but you're only going to know that if you put a central line in. And we don't routinely do that in the ER. So very vague symptoms. Unusual sleepiness, well, whatever. Everybody has
Is
that.
one where you have like the killer headache too, or?
Yep. Fever, nausea, vomiting, headache, decreased appetite, neck stiffness. This is the one where they have the rest of them, and they're talking about they just can't seem to rotate their neck. This is a big red flag. I'm grabbing everything to do with spinal. I'm not even asking the doctor if he wants it, I'm grabbing.
Every time I say I have a headache, I'm always like, can you move
This
your neck?
looks like
Like,
a
actually, you're
migraine.
good.
All right, seizures. Let's talk about seizures. What is the big seizure everyone always talks about?
Static epileptic.
The grand mal.
The grand mal, which is called tonic-clonic.
I don't even know what I'm talking
I don't know what you're talking about either. Like,
What did
what is
she
she like?
Never heard of that.
Grand mal.
Tonic, clonic?
Tonic-clonic. Tonic-clonic. This is generally called the grand mal seizure. This is the one you're going to see in a good ER episode of Grey's Anatomy. This is where the patients walk in, they fling themselves on the floor and start shaking. Okay, that's very, very dramatic. Okay, but one of the more common ones you see is the absence, which is the person has a seizure and you have no idea they have it. They're just sitting there chilling, and you just think that they're kind of dazing off. We've had children come in to the ER, and when we hook them up to the machine, they're having a dozen seizures an hour,
Wow.
but you have no idea.
Their eyes roll back?
No.
No, they're
Just-
staring into the void.
And, but, you know, I have a 9-year-old daughter. Sometimes she just stares out the window, and I'm like, "You all right?" She goes, "Yeah, I'm just thinking."
Space
All
cadet.
right. Just contemplating the meaning of life. I don't know. All right. So your simple partial, which means the things you're going to see, the jerkingness. They're going to be weak, but that's not something you're going to care about right now because they're probably on the floor. Sensory changes. You ever hear someone all of a sudden they're tasting something weird or they see a halo effect? Get them down on the ground. They're about to have a seizure.
When I pass out, when I get shocked, my hearing goes out.
Oh, yeah.
Like, I can't hear anything, I'm boom.
All of a sudden they're sweating, their heart rate and the respiratory rate goes really, really high. Some people say they have some kind of psychic sensation. I don't really know what that is because the only thing I've ever heard is the halo effect, so I don't know if that's what they're referring to.
My cousin smells like oranges.
Yep. See things, they smell things, they taste
She
things.
smells oranges, it's weird. Mostly because I eat oranges all the time now. I'm gonna do it at a wedding, just peel open an orange.
That's just mean. You walk up to her and be peeling an orange. And I'm like,
About the body
All right.
parts and some spray.
the phases of a grand mal seizure: the aura phase,
The
the
side
tonic phase.
The slide before this doesn't matter.
What?
We went through it already.
We already went through it.
Oh.
Sorry.
Are you just supposed to hold their head while they're doing
No.
this? No, you
No,
don't?
just
We'll get there.
shake.
So, and then the post-ictal sleep. The post-ictal sleep phase is one of the most dangerous phases for the healthcare worker. Do not try to wake them up as long as they're breathing and they're not choking on their tongue, let them roll. You try to wake them up, you're going to be the next patient in the ER. Because their adrenaline system is working overtime because of what just happened. And I've had patients wake up and do a right hook like I've never seen. And I've had healthcare employees, my coworkers, be punched across the room. I mean, fly across the room. So you've got to be really careful. So let's talk about what happens when there's a seizure going on. Do not put anything in their mouth. Don't, okay? Even if their tongue has come back into their mouth, you still have 3 minutes before you have any sort of brain damage. And so you have time to fix that. So let's go through everything they're doing. They removed his glasses. Why?
It doesn't.
Stab him.
Glass. They'll stab him in the eye or the face. The lady on the bottom cushioned his head. Okay, so this is post-ictal. Why do we care about timing the seizure?
Brain damage.
Brain damage. We want to know how long the seizure. The healthcare workers, we're going to want to know that. Do not hold the patient down.
You could break. Yeah.
You could break a bone.
I've literally seen cops hold someone down having a seizure. and I'm
They
like,
just
what the hell are
don't
you
they just don't
doing?
know. You gotta remember, cops have BLS training and that's it. Guess what? BLS does not cover seizures. ACLS does.
No.
BLS does not. Okay. They loosen any tight clothes. Loosen the tie. Do some buttons if you have to. Loosen a belt. Okay. This is gonna be very uncomfortable. They're gonna be very sore when they wake up. And why do we turn the patient on their side?
Aspirating.
Aspirating.
Does it matter what that?
It does not matter what side.
Okay.
Whatever side's easier. Now, it's perfectly okay if someone is having a seizure on the ground if you're holding them on their side, as long as you're not holding them down. Okay, and let me tell you, if you're out in the real world and someone starts swinging, let them go and get out of the way. Okay, it's fine. Because if they're swinging at you, chances are that they're coming out of the post-distal phase and they're doing okay. All right, any questions with seizure? All right, multiple sclerosis. Tell me what you know. It's awful. That's all you need to know.
Very nasty.
It's very nasty. Why is it so nasty?
You can't walk, you have problems with gait, you lose control of your bowels and your bladder.
For me, the worst part about this is mentally you are completely cognitive the entire time that your body's failing. And there's nothing you can do about it.
My sister has this.
Oh. Hush it. There are different forms of MS too. There's several different forms. My uncle's had MS for about 20 years and he has very little effects. Okay? It will as he gets older come more prevalent. I see my dad's so 66. So but as he gets, I've already seen it. And he smokes like a chimney, which I wish he'd stop doing that, but
My
whatever.
sister smokes too.
Sometimes I think they just do it because it's just a surplus, you know.
So sometimes, my mom was all upset with him for doing it. I said, at this point, I don't know that anything would change even if he stopped. And at this point, with the MS, if he stopped, it actually could cause more damage than good. So, but he knows what he's doing. Or he knows the effects of what he's doing. So immune-mediated inflammation disease of the central nervous system. So basically, it's breaking down your neurons. And those aren't things that we can get back.
It is auto.
The older you get diagnosed, typically, the less severe the MS is. The younger you get diagnosed, typically, the more severe it is. I say always typically, because in the medical field, there's always exceptions to every rule. Okay? So how do you diagnose MS?
Scans.
MRI, CTs. So we want to see if there's any of the plaque present. There's a certain type of MS plaque. We're going to do a spinal and see if there's any elevated protein and WBC counts. There's going to be abnormal electrical activity in the muscles associated with the nerves. You're going to have nerves firing where muscles don't respond, and you're going to have muscles responding where there's no nerves firing. Everything's just kind of doing its own thing. So your nursing diagnosis is, give me what you think some of the most important nursing diagnoses are.
Risk for injury.
Absolutely.
The depression.
Respiration.
Aspiration. Eventually they will not be able to swallow.
Ineffective breathing.
Yeah.
This is a death sentence to somebody. It just matter, they will die of this. It's just a matter of when they get there. But again, I know people that have had MS and they've had it for decades and they're working full time and they have a family. It just sincerely just depends on what's going on. One of my biggest things with it is I see my aunt not doing well. My aunt looks sicker than my uncle because she's his caretaker, even though he works full time. But she is so chronically worried about him and what's going to happen next, and every day is he going to be able to walk the next day. That there's the coping that the caretaker has is almost more strain than the patient going through. So what kind of medications do we give?
Muscle relaxant.
Muscle relaxants?
My patient in ambulatory had to come in for a 5-day infusion the day after you got diagnosed with it.
Okay.
I totally forgot the name of it, but that, whatever it was.
It could be, it was probably, and I don't know, it was probably interferon.
Yeah, I think so.
Okay, I can't, that's just what I'm guessing.
It sounds familiar.
Okay. That helps the immune system boost, and it helps prevent the spread of the MS. So they probably wanted a really high interferon count to see if that was going to do anything to the nerves. So
I know medical marijuana actually helps a lot. With
It does.
My sister
it does.
uses medical marijuana.
It really does. Medical marijuana helps Parkside patients. Parkinson's patients. It might help Parkside. Okay. All right, any more questions on MS? All right, keep going. Myasthenia gravis, autoantibody attack on your own muscles. So in this case, it's not attacking the nervous system as much, it's attacking the muscles to a point where the muscles are so weak they're not responding to the nervous system. So the nervous system could completely be 100% working fine, but the muscles aren't responding as well. So there's several different, there you go. The motor response, your muscle weakness, makes sense? It does improve with rest. So what is a nursing intervention for this patient?
Rest.
Rest. What else you got in there? You guys talk.
For motor stuff,
Mm-hmm.
the loss of bowel and bladder control.
Yep.
Fatigue.
Because the muscles are, yeah.
Chewing and swallowing the muscles.
Yep.
Difficulties in
So-
breathing.
What is, I can't read that before Holy, or I can't pronounce it either.
Ptosis?
Oh,
is that
yeah,
what
I
it's-
don't like that.
Poor posture, trouble breathing.
Oh, yeah.
Sensory, muscle aching. They just constantly have a muscle aching. Unfortunately, a lot of times people get diagnosed with fibromyalgia before the doctor figures out they have this. Because one of their biggest complaints is muscle aching. So, and guess what? After they go and they walk for half an hour and then they rest, they feel better. Well, what is the number one intervention for fibromyalgia?
Rest.
No.
Exercise.
Exercise. But guess what? These patients go out and they walk for half an hour, but then what do they do after that?
They go to
They rest, so it looks like it's fibromyalgia. So that's why it constantly gets done with fibromyalgia first. Things that make this worse. Cardiac medications, antibiotics, antihistamines, so if you have allergies, I'm sorry, opioids, alcohol. You guys get that?
Is that because most of them are like relaxing the muscles?
They're trying to control the muscle, which is going to be difficult for them to do anyways. All right, questions on that? To Parkinson's disease. So this is what a typical Parkinson's patient can have. Doesn't mean they do. Not every patient is going to have everything possible listed for a sign. Some things are much more in stage 4 of Parkinson's, like the flat affect that Parkinson's patients have. That's typically later. So let's talk about the stages real quick. So stage 1, minimal weakness, hand and arm tremors. Am I dating myself fast? Any of you who are Michael J. Fox is?
Yeah.
Do you remember his first tremor, where it was at?
His thumb.
He was filming Back to the Future, and he said his thumb kept trembling. That was his first one. A stage 2. So stage 2 will have everything stage 1 has, and they'll have a mask-like slow shuffle gait. You ever see the patients with Parkinson's? They're really slow. They're very, 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 very purposeful. Stage 3,
Wait,
they'll have,
Is that like a mental thing that they're not walking?
it's a nerve, it's a muscle.
It's
nerve.
like, so they can't
can't.
walk.
They cannot do
faster
this.
than that. Okay.
No. And by that point, usually, they're kind of going down a little bit too. Stage 3, increase in gait problems. And then stage 4 is exactly the opposite. It's a rigidity. So once you've gotten here, every muscle is very rigid. Well, guess what? Working in surgery for 6 years, Parkinson's patients, they come in, we give them anesthesia. Anybody has any idea what happens as soon as we give them anesthesia? They're completely relaxed, the tremors are gone. We can do full range of motion with them without a problem. The problem is you can't live on anesthesia. Not possible. But what have we found in the last 5 years that has the same kind of effect of anesthesia, but the patient absolutely can have an everyday fulfilled life?
Is it, yeah, it is marijuana, isn't it?
It's marijuana.
Really?
It's marijuana. There's multiple videos, and you can YouTube it. I don't have a video for it, but patients that have severe Parkinson's that smoke marijuana, within a couple minutes, all their symptoms are gone. So.
What's the kinesia? The kinesia?
Mm-hmm.
Is there a difference between smoking marijuana and eating edible?
I don't know. Everybody I've ever seen use marijuana always smoked it for disease processes, so I'm not sure.
I was told that it's the same effect, but smoking it hurts
Is
your
it fat?
lungs.
Well, the oils
I
are
think
good.
smoking
The
it
oils
gets
are
it
just fine.
quicker.
I think
No,
eating
eating
is a
it
more
is the same
body
thing, it goes
part
right
of
into
the
your-
mental
Well,
body.
and the oils work, the oil that they take from the marijuana plant works the best. And that's what Wisconsin, at the end of last year,
Yeah.
wrote into law. We actually give it to people for seizures now. So, and it's very good with children. And I know that before that, there was a lot of people that were very pro marijuana, and they're like, oh, just let the kids smoke. Well, no, because that's still a lung issue.
Mhm.
And smoking marijuana is still a smoking substance, and there's still chemicals in it, even though they're grown chemicals, and they can still hurt your lungs. So I'm sorry, I don't want any children smoking marijuana. But now that we have the oil, we can put them in capsules, and we're seeing some really good results with it. I know UW-Madison's doing a lot with it. All right, we've talked about that.
That's gonna be crazy.
Will they
one
die
Oh,
day
from Parkinson's?
They do, typically a person does not die from Parkinson's, they die of something related to the Parkinson's.
Okay.
They can't get up and walk, or they try to, so they fall and break a hip, then they're in the hospital, now they've got an infection, now they got pneumonia, and then they die from that.
If it
No, we can
progresses
see.
far
Guys.
If it progresses far enough though, can't because they start having swallowing issues
Yeah.
and then they basically aspirate.
They won't be able to swallow, and after a while, their diaphragm will stop working, and they won't be able to breathe.
We could, possibly in the next couple of years, see that that's changing because of the marijuana.
I hope
treatment?
so. It won't stop the disease
Does it stop the
process.
progression. Okay.
It will just slow down the symptoms. The symptoms will be more managed.
Okay.
That just be real careful. I know there's a lot of pro marijuana people out there, and it really does help with with signs. Symptoms of disease process. There is no evidence it cures anything.
Mhm.
There's not one shred of evidence out there, and Berkeley's doing stuff, and UCLA's doing stuff, and the Mayo Clinic and Cleveland Clinic. There's no evidence it cures anything. There's all these Facebook things that it cures cancer. There's not one
My friend from
shred of
California
evidence.
is like, yeah,
I-
it cures everything.
Yeah, so
She's
It
always
does
fine,
do
that's how
great
she talks to, like,
it does great things for the effects of some disease process and the side effects of like chemotherapy, and it does great stuff like that. There unfortunately is no evidence.
Isn't there also like the side effect disease, like where they get the super intense abdominal pain if they're using it too much?
They can. I mean,
That's
you-
for
any-
the munchies, girls. That's all that bad stuff.
No, like they thought it was, like in Colorado they were having a higher incidence of it because it's legal and people were smoking a lot more. And I think it was like,
Causes abdominal pain, really.
I mean, it was people that were smoking like every day all the time.
I think that was more the munchies.
I did read an article
Yeah,
that the
that
Girl
might be-
Scouts in
yeah.
America are all mad at some troop in Denver for posting,
Dispensary.
for setting up their cookie stand outside of one of the dispensaries. I thought it was brilliant.
Brilliant.
Then you
She
get in
had
trouble
it in
for
a wagon, so she was walking it up and
Oh, it
down
was in a
the
wagon. See, she
street,
wasn't
so
even
she
really parked
technically
there.
wasn't
She
in
was
front
just
of it.
walking with her cookies. What's the problem?
Well, look how good Willie Nelson's doing.
He grows his own though, so he knows exactly where it comes
I
from.
know my cousin makes the containers for them.
So does my grandpa.
There you go. See? All right, we're almost done. ALS. Anybody ever do the ice bucket challenge?
I did.
Anybody know why you're doing it? I couldn't tell you how many people on Facebook
I know,
are doing
that
it. I'm like, why are you doing it? I don't know.
Exactly. I'm like, you didn't donate anything.
I'm like, did you donate the money? No.
No.
Okay, well then I'm done with you.
You just look like a.
Like you just got really,
I
really
used to-
cold for a second.
I used
Thank
to-
you.
Like t-shirt contest.
No, okay. So onset is between 40 and 70 years, and the death. There's not been one patient that's been diagnosed that lived over 6 years.
Wow.
So it is very rapidly. Unfortunately, it's more common in men, or unfortunately, I don't know how you look at that. So what are the signs and symptoms?
It will not live over 60?
6 years after
Oh,
it's
I'm
been
sorry.
diagnosed. I'm sorry.
Okay.
It starts very slowly, something shuts down, like your feet, all of a
Mhm.
sudden you can't move your toes,
Yeah.
and you can't move your ankle.
You're
you
very,
can't move
very
your
weak.
knees.
Yep.
'Cause this
All of a sudden, your joints stop working. Then you get the muscle wasting because you can't really move. Then you get the pain because you're not moving and your muscles are dying off. Then you have sleep disorders.
My great
It
grandma
is-
had this.
It's an awful, awful disease. ALS, or it's called Lou Gehrig's disease.
Doesn't it skip a generation? So like since my great grandpa had it, my mom has the chance of getting it, and then my kids will have the chance of getting it.
I don't actually know the genome on it, I'm sorry.
That's all right. All I know is I'm in the clear if it skips. So
I hope it gets for yours. And then Huntington's disease. Just a fairly, really horrible disease, just like the other ones. This specifically targets the nerve cells in the brain. how would somebody look for Huntington's disease versus ACLS?
Mentally?
Mentally.
Oh, it's mentally?
This is a mental thing. The nerves and the brain are being affected. Just the brain. This patient won't know they're dying. They'll get to a point where it's kind of like Alzheimer's, they won't remember anything.
Is this painful?
It can be, and it doesn't always is though. The most common way an individual that has Huntington's disease dies is pneumonia, and unfortunately, anybody could guess the second.
Like
Aspiration?
accidents.
It's not an accident.
Suicide.
Suicide.
Oh.
Suicide's the second most rate for ACLS. I mean for Huntington's disease. So on that horribly sad note.
So,
Yes.
Are we having-
So we get June.
oh heck yes. Are we
We're still
having
being recorded.
the quiz next week then?
Yeah, that's actually what I was gonna pull up next is the quiz.